So someone asked me last week if retinal degeneration was like having acid spilled on tissue that it degenerates. So it's actually not like, it's not as violent as that. So retinal degeneration doesn't mean that the retina just disintegrates. It means that there's a slowly progressing disease of different cell types in the retina, and most often we refer to the photoreceptors, which are the light-receiving cell of the retina. So the retina is like a Polaroid film for the old guys like me, and for the younger guys it's a bit like a microchip. So it's a multi-layered, very complex system that has numerous different types of cells to send an image, a clear image, to your brain. It works very hard. It's actually the part of the body that has the highest metabolic activity. So if there's one part of that microchip or one layer of the Polaroid film that's not functioning completely, the processing of light becomes abnormal. And the parts that are most often affected in retinal degenerations are the photoreceptors. So those are the light-sensing cells of the retina. There's the rods that make you see in a dim-lit environment and also allows you to see in the periphery because that's where they're located. And there's the cones that allow you to see color in bright light and well in the center because that's where they're mostly located also. But it's never an all-or-nothing system. These two systems are tied together, which leads to the complexity of retinal degeneration. So they come in all sorts of flavors. You may have heard of RP, rod cone dystrophy, cone rod, cone, Stargardt's. These are all different types of retinal degeneration. And people want to know what type they have, in part because that helps us better understand the progression, what to expect, and what the opportunities are. In many cases, the retinal degeneration is progressive. It's usually slowly progressive, but in some cases, it can be a little bit faster. And that difference, in large part, we think, is due to a genetic variation in your system that we refer to as a mutation. So we now know that retinal degeneration are due to mutations in hundreds of different genes. And so the identification of those genetic variation has been quite complicated through the years, but now through neurotechnology, we're a bit better. So to make a diagnosis, we need several things. We need to know about you. Like some people just like look at my eye and tell me what I have. And like I tell my colleagues in medicine, is that the eye is part of the body. Okay, so it seems like obvious, but actually a lot of people forget that your general health, who you are, what you've been through, will influence your eye status. So that's why we need to know about you and about your family. We need to know how your retina functions. That's why we do the horrible Electroretinogram. We also do visual field tests, etc. And we need to know how does the body of the retina look like? So that's why we take pictures, we do tests such as OCTs, etc. And we also want to know what's the genetic variation that underlies the degeneration of your photoreceptors. And that's why we always recommend genetic testing for a reason that I'll elaborate on in a few minutes. So let's look at this in a little bit more detail so you understand why we do all those things. So I want you to know that we totally realize that how we measure vision and how we tell you that your vision does not reflect how you see. We do realize that. So we do realize that the way we measure visual acuity, contrast, and the color is an under-reflection of your visual potential, but it's a standard. And that's why we need to use those tools, because everyone uses those tools, and it's the closest that we can think of to what you see. So that's why we do other tests also. We'll do the visual field. The visual field is important to let us know how far do you see and where do you not see. Are you safe? Are you safe getting around? Are you safe driving? And how can we help manage those changes? And we need to repeat those tests over time because these observations will change over time. Many of you may have had an OCT. An OCT was introduced in our practice about less than 10 years ago, really, and it's changed the quality of care we can deliver because we see so much more. It's like a histological section of the retina that we see through a simple image. So we can see the layers of the retina and we can understand better which cell type is more affected and to what degree. So it's a very, very useful tool in understanding retinal degeneration. And in many cases also it allows us to see whether there's macular edema, which is like a blister, a swelling of the retina, that in many cases is manageable if it's taken on time. And otherwise it would be hard often to detect that complication of the retinal degeneration. The beauty of the OCT is that it's easy on you, and it's easy for us to perform. So even little children often are able to go through an OCT imaging. This contrasts a bit with the electroretinogram. How many in the room have had an electroretinogram or an ERG? How many have liked it? I don't see any hands, but one maybe. So the electroretinogram is a very useful test to measure the electrical activity of the retina. It allows us to measure the electrical activity of the rods and the cones and how they interact with each other. Luckily, we don't need to repeat the electroretinogram frequently, but in some cases we do. So the way this works is that through selected different light intensity, the response of the retina is recorded. And that's very, very useful in making the diagnosis. And also, there's some genetic mutations that have a unique electroretinogram recording. So it's very important to do the electroretinogram. What's interesting, it's so sensitive. You can have a very poor electroretinogram recording and excellent vision. So sometimes patients or families are very disappointed either to hear the electroretinogram is not recordable or it's severely attenuated. The recording of an electroretinogram is not vision. Okay, so they're two totally separate things. These are all tools that we accumulate to make the diagnosis more precise and to guide you as best as we can. So to know really the cause of a retinal degeneration, what we've talked about up to now is what's happening, where are we at. But to really know the cause of why this happened, we need to know the genetic mutation. And initially when I started, I remember vividly how naive we were, and I've told this story before. The rhodopsin genes had been identified, and we were in the clinic, and then there was a new gene, the RDS gene, that was identified. And we thought we knew everything about retinal degeneration, and all we needed was a treatment. And we used to say, in 5 years, everything's going to be fine. And we're many years later, and those of you who have heard this before, we don't give any timeline anymore, but we can say that the amount of knowledge that has accumulated is just incredible. And the opportunities that are ahead are incredible. But you need to remember that what's most important to scientists and to physicians is to first do no harm. And it takes a long time to translate that genetic scientific knowledge into practice. So we know that that's frustrating. Our ability to identify a genetic variant today, some people call them defects, but we call them variants because it happens, we carry a lot of variants, and that's why we're all different, actually. Our ability to identify a variant or a mutation is very good. Like we looked in our database recently, and at least 60 to 70% of our patients have mutation identified. And I'm going through, and those who do not have mutations identified have been lost to follow-up. So sometimes patients move and we don't know, so we can't track them again, or they're seen elsewhere, they're not seen again. So the technology has evolved tremendously and empowers us in delivering a genetic result more quickly. But these results need to be interpreted with caution. And we've learned that in the hard way, is that in our body, we each carry hundreds and hundreds of variations. That just makes what we're different. And sometimes there's some unfortunate ones that will hit a more important gene and cause a phenotype that's more severe, such as retinal degeneration. In order to say your retinal degeneration is due to gene X, we need to be really sure that that's the case. Because if that's not the case, what happens is that we've put you in the wrong box. And it's not right, it's not fair, and it would prevent you accessing certain opportunities in the future. So we're very, very careful before delivering a result, and which is why we don't recommend people contacting genetic testing companies directly just to have a test done and rely on the report that's given to you. We study the reports and we correct the reports not infrequently. So the interpretation of those results is not trivial, and you actually cannot interpret a genetic result without a clinical diagnosis, because they go hand in hand. So, for example, if you measure your blood sugar and it's high, it doesn't mean you're diabetic. If you just had a big piece of cake, it doesn't mean anything. And so people have to be very careful in interpreting genetic results without a sound clinical evaluation. So why do we want a genetic result? And there's a lot of anxiety around not having a genetic result confirmed. Like, are you missing on something, and is it damaging to not have a genetic result not identified? So we want to know of the genetic cause of your condition for various reasons. It helps us first understand the nature of your condition, the inheritance. What is the progression likely to be? Because we have information from other people who have similar changes. And we need to know what we treat. We need to know exactly what is the basis of the problem. And of course, we know that certain therapies are being directed to certain genetic variants. And there's some clinical trials that are ongoing now, and there's been very positive results, and that there's been no adverse event to date. But there's a lot of hope that's been created, and very, very high expectations that have been created around the importance of having a genetic defect identified. And I want to say that despite the unbelievable advancements, and Dr. McInnes is going to talk about that after this session, there's no cure. And Dr. Berger mentioned that. Our work is to try to find a cure or to find a treatment that's going to significantly improve the visual outcome. And so some people think because they don't have their genetic defect identified that they're missing on a cure, and that's not the case. So it's still important to refine the clinical diagnosis, and that's why we have you come back. There's something that's been underestimated, is the importance of the natural history. So how does the retinal degeneration progress? Gives us a lot of information, first in understanding what could be the genetic defect, And also understanding what are the right timing of intervention. You need to know what's happening in terms of vision in order to be able to measure success. So that said and done, not all genes have been identified, and we still have a lot to learn. And we need to be realistic in our expectations. So what do we do in the meantime? We still have a job, and we'd like to think that we still offer a lot to the patients through our evaluations and our follow-up. And I want to emphasize that follow-up is important because it allows us to document the natural history. So it's part of the management of the disease. It's important to follow up also because people with retinal degeneration are at the same risk of developing glaucoma, for example, which is a treatable cause of vision loss, but much harder to diagnose in the case of a retinal degeneration. So especially for adults, that's very important to keep in mind. Also, the vision may decrease because of a cataract, and in some cases, it may be indicated that the cataract be removed. And those are important issues to discuss with your primary eye care provider. In some cases, as I mentioned earlier, individual may develop a blister or macular edema behind the eye in the retina. And in many cases, this is manageable through either drops or medications. But if we don't see the patient in clinic or in follow-up, we can't know that. And a very important aspect is refraction. It's amazing how people still have impaired visual acuity that are just due to the wrong glasses. And having your glasses adjusted are as important when you have a retinal degeneration than for those who do not. And that brings us to low vision assessment. The field of low vision improvement has evolved significantly, and we highly recommend for individuals with a certain type of impairment to get a low vision assessment. So what do we recommend in the meantime? We recommend a healthy diet rich in omega and antioxidants, and there's going to be some talks this afternoon on eating well for your eyes by Dr. Bakshi. We do not systematically recommend supplementation of vitamin A. Some people say, well, vitamin A is good for your eyes. Your eyes need vitamin A, therefore you should just take more vitamin A. Vitamin A is a little tricky. It accumulates in your body, and if you take too much, you can create harm. And so first, when you take it, you need to make sure that you take the right dose and that your system tolerates that dose. Now, this said and done, there's some indications for supplementation of vitamin A that are related to specific genetic mutations. And we like to know that the individual is in that category before we recommend supplementation of vitamin A. Not infrequently, people will self-medicate with some vitamin A supplement and will take more than they should, and you can create retinal damage by doing that. So it's been shown through animal studies that smoking accelerates retinal degeneration. And also it's suggested that excess exposure to UV light also is not good for retinal degeneration. We routinely recommend supplementation of antioxidant, in part because there's no evidence that, anyway at this point, that too much oxidant or anyway the prescribed dose of antioxidant can create damage. And there's animal work that suggests a trend towards slowing down the degeneration of the retina. Lastly, I would like to talk about stress. And we often don't talk about stress, but having a visual impairment is stressful at many levels. I don't need to tell you. But we know that stress also affects retinal degeneration. So there's animal work that's been done that suggests that being in a less stressful environment will not slow down, I should say, being in a more stressful environment, can accelerate the retinal degeneration. So there's a great incentive in self-improvement in trying to understand the triggers of the stress and how that can be better controlled. So I think I'll stop here and I'll open the session for questions, as there's a variety of people in the room.
Thank you. I have two questions. The first one is, are Best disease and vitelliform pigment epithelial dystrophy inherited diseases, retinal diseases? And the second question is, are they connected?
So the question was, and Jamie, there was a question in the front that I'll repeat, is what does OCT mean? And so I apologize for having used the acronym. And I'll just say that because it's quick, and we do use the OCT in your condition, sir. So the OCT stands for optical coherence tomography. So it's an imaging technique that we use. It's a simple imaging technique from the user's perspective. You put your chin in the machine, and there's a series of thousands of scans that are done in the retina, from the retina. There's no radiation at all. It's an ultrasound-based technique. And it gives an image, a side view image of the retina that allows us to see the different layers. So because optical coherence tomography is a bit of a long term, we refer to it routinely as OCT. So I apologize for that. So the question was, is Best disease and vitelliform pigment epitheliopathy, or we also have the adult vitelliform disorders, are these inherited? They are genetically determined, and there's different genes that are responsible for the early onset version and the adult onset version. In the early onset version, we refer to Best disease, and usually the diagnosis is made in the first decade of life, but it can be made later. I'm trying to not go too complicated, but what we've learned about Best disease, the gene responsible for Best disease causes also parallel diseases. And so sometimes that's where there's confusion. So we can give different names to the condition, which is a clinical description of what we see, but the genetic defect is similar, and vice versa. So the clinical name we give to a disease like vitelliform maculopathy can be Best disease. It just says that the maculopathy refers to a disease of the macula, and vitelliform just refers to like a formation of an egg-like lesion, because that's what it looks like when we look. And so you can have vitelliform maculopathy due to mutation in the Best disease genes as much as mutations in different genes. Does that answer your question, sir? Okay.
Anyone who has 34 years old age has central cataract. She has central cataract, and she has RP together. Mm-hmm. I mean, she's suffering from the RP. Is it possible to first do the cataract and or wait for find out any cure for the disease?
So I think your question is, when cataracts, which is an opacity of the lens, develops in an individual with retinitis pigmentosa, is there a possibility to remove the cataract to restore some sight, and then the person would also be eligible to other treatments? So it all depends. And so the decision of removing a cataract in a person with RP is not something that we take lightly. You can have a cataract that doesn't change, and it doesn't really affect your vision, because your retina, the damage of your retina is what determines your vision. It's not what the lens looks like. And so what determines if it's worth removing a cataract is if there's been change in the vision related to the development of the cataract. And we take in consideration also the size of the visual field and the damage of the retina. There's some individuals who have greatly benefited from cataract surgery who are affected with RP, and many have not. And it's really important to set the expectations right, because some have been very, very disappointed of not having been improved, and some have lost vision. So it's not an easy question. So it's not like in the general population, if you have a cataract, you just remove it. They remove like barely any cataract. But it's something that needs to be decided with the patient, what the expectations are, what do you want to get out of it. So sometimes someone will say, this glare that I have is crippling. I can't stand it anymore. It's crippling. And you say, okay, well, with this type of cataract, if you remove it, you will get rid of the glare. Like if there's no complication, but an intervention is always an intervention, so there's always a risk. For someone who says the glare is crippling, often we'll say, okay, well, then we would recommend for the cataract to be removed. And so it's really on an individual basis. There's no magic answer.
Hi.
Yes?
I have a two-part question.
Yes.
With regards to inheritance, is RP something that can be inherited every generation, or does it skip generations? And second part of that question, is there a way of getting tested if you carry the gene?
Could you repeat the second one?
Yeah. Is there a way of getting tested if you carry the gene of RP?
Mm-hmm. So maybe, Heather, you can come up. So I'm glad there's a genetic question. For those of you who have been seen at Sick Kids, there's been many changes that I understand is leading to frustration. And we have a new genetic counseling team. And Heather, if you can stand up. Heather Trang is our lead genetic counselor. And I'll answer to my best. And if she wants to correct me, she'll come up. Okay? Let's put it that way. There's different forms of inheritance of RP. And so it doesn't always affect every generation. The only one that tends to be transmitted vertically from one generation to the other is what we refer to as autosomal dominant. And usually when you have an autosomal dominant condition, if you're affected, the risk of passing it on is 50%. In our part of the world, this is not the most common cause of inheritance. Most cases that we see are sporadic, in part because we have smaller families. And so we only see one individual with no family history. Am I correct, Heather? Okay. And so we assume in sporadic cases that the inheritance is autosomal recessive, meaning that each parent would be carrier of the genetic defect, and having both mutations makes you express the disease. If you stay out of your gene pool, in principle, you're not at higher risk than the general population. And so usually the sporadic cases or the autosomal recessive inheritance, unless you're in a very closed gene pool, does not go from generation to generation. And I just don't want to take all the time to the questions because we can talk of inheritance, but I encourage you to talk to Heather if you want after, if you want to know more about inheritance, because it's an excellent question. Thank you.
You talked about low vision assessments. My son's been examined by a number of very competent ophthalmologists. What is the added benefit of a low vision assessment? Does it encompass anything extra? And again, I guess mainly what would be the benefit of that, and where would you get it?
So what's the benefit of a low vision assessment, and where do we get it? There's different type of low vision assessment. I'm not a low vision specialist. There's what we refer to as a low-tech vision assessment and a high-tech. So the low-tech would be using vision aids, modifying the current prescription to enhance the sight, either through magnification or sometimes prisms. By displacing the image, you can enhance the size. Playing with contrast in the lenses. There's lenses with different contrasts. Utilizing little microscope. You may see some people around here that have little microscope on their glasses. There's a new technology that's arisen that's being tested called e-sight. That's a special sight of glasses. And that brings us into the high-tech. So the high-tech would the individual benefit of certain computer program that facilitates the reading of the text on the computer, or with the individual benefit of, how do you say, when the computer talks back to you? Screen reader, thank you, etc. So there's different specialists that deliver low vision program. The CNIB is one of them, where they would deliver both low-tech and high-tech. And then there's individual practitioners that we could refer you to, or the CNIB may have a list, or the Foundation Fighting Blindness may have a list. They could be optometrists, they could be ophthalmologists, but they have certain credentials and they're authorized to be a dispenser or a prescriber of devices that could be subsidized by the Assisted Device Program, ADP.
I'm afraid I have to cut off the questions because it's time to thank Dr. Heon and for sharing her expertise with us. And yes, let's give her a big round of applause.